move the meeting, but unfortunately one of the reports wasn't going to be ready for the allocated date that we already had in our diary. So thank you all for changing. I know it's a bit difficult, especially if you work. Right, so before we start these proceedings, may I bring to your attention to some housekeeping matters. There is no expected alarm testing today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house. This meeting will be broadcast live to the internet and will be capable of subsequent repeated viewing. By entering the Warspite room, committee members are consenting to being filmed throughout the meeting and to the use of those recordings for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it is switched off when you are not using it, and that your mobiles are turned to silent. Thank you. Elliot, apologies.
Thank you, Chair. We've received apologies from Councillor McClay.
No substitute.
Not aware of one, Chair.
Councillor Penrose will be here. She's just going to be a little bit late, but she will be here. Item 2, declarations of interest. Anybody got any declarations of interest? Will?
I work for Plymouth University's Hospitals NHS Trust.
I do as well when they've got a shift for me.
Okay.
And I work for University Hospitals Plymouth too.
Anybody else? No. Approve the minutes of meeting held on the 15th of July. Those that are present, can we have a proposer and a seconder, please? Andy and Ray, got it? Thank you, Elliot. Item 4, Chair's urgent business. No, I ain't got any today. Thank you. Unless you want me to talk about my dog or what. Item 5, Adult Social Care Finance Report. I've got Helen Slater. Thank you, Helen.
Hi everyone. So we've got the month 6 finance report for you here for adult social care. Within the Adult Health and Communities Directorate at month 6, there was a pressure of just over 3 million, of which within that is 2.243 million pressure in adult social care. So the report lays out some of the main areas where we're seeing the pressures. So 824,000 of that pressure is within domiciliary care, as we continue to see an increased demand for intermediate care to support clients discharged from hospital. The biggest part of it at 3.519 million pressure relates to bedded care, so residential and nursing care coming through each pathway, and then 477k across other care packages as wait lists have actually been reducing. Obviously, it has a financial impact. There's a direct correlation between increased expenditure and income, both through joint funding and client income. So we were able to offset some of these pressures by 2.310 million of additional joint funding and client income. We have set up a new joint funding panel to make sure we're getting as much as possible for those clients where needs are shared across social care and health. So that, I think, started last week. We have set up the Directorate's Budget Containment Group, and they've been tasked to look at the high-risk areas. Work initially identified includes analysis of dom care, better care fee levels, pipeline demand, timescales, and planning in increases in client direct payments. There's also been a focus on the short-term residential clients, as we're seeing quite an increase in that, to identify any barriers there are with those clients to long-term care. Within adult social care, we have made 75% of the in-year savings target, so that's 2.074 million, and that's been achieved to date, with the rest flagged as amber for the rest of the year. Just an update on what we're working on at the moment for our budget for 26-27. So we're making assumptions about national living wage. So we're assuming at the moment that for our modelling that will be £12.80 per hour, but we wait confirmation for that. And we also are making assumptions about inflation. There's a lot of uncertainty still at the moment about the level of funding overall for PCC, and we had the policy statement yesterday, so that's been analysed and modelled. So significant work still to do on the budget and pressures within year, which will knock on to the demand for next year's budget. So I don't know if anyone's got any questions.
Thank you, Helen. How confident are we that we're actually not gonna, we're gonna meet our targets? Are we confident? Are we?
Savings targets. Yeah, I think so. Gary, did you have anything you wanted to say on that? Sorry.
I'll move things on. In terms of the targets we set at the start of the year for our savings, I think we're looking fairly good on track. There are some risks in that, but we manage those throughout the year anyway. So that, I think 75% progress at this point of the year is good and quite positive. Clearly what Helen's talking about are some of those in-year demand-led pressures that we've seen to a greater extent than really expected at this point of the year. But yeah, our savings plans we're doing well. Yeah.
Andy?
Just a quick question with regards to contingencies. So we're making an assumption that the minimum wage go up to £12.80. If it goes any higher, we got a band the contingency, please.
So we do model various different scenarios. It will get, if it does go up higher, it will get fed into the MTFP model, and we don't as such have a contingency line for it, but we do know that that is the low pay commission model at low, medium, high. So we are aware that it can swing. So that's something we're always bearing in mind, and we do the sensitivity analysis as part of the MTFP.
Anybody else? Sorry, anybody else got any questions at this point? No, any recommendations? I mean, obviously we've got budget scrutiny coming up in January, so I think what we'll be able to do is probably whatever you bring in, we'll probably be able to scrutinise from there. So thank you, Helen, and thank you for the team for, you know, being on target for your savings. It's you know, it is amazing in this day and age. It's like, you know, we're always going to be expected to be over budget, but well done to all of you.
Can I just say, I'm getting replaced by my colleague Becky, who's over there, so she'll be here with you guys next time.
Are you leaving us, Helen, are you?
No, I'm just doing additional stuff
Oh,
to do with the MTFP. I can't escape.
Okay. Nice to see you, Becky. Hello. Okie doke. Thank you, Helen. Adult Social Care Activity and Performance Report. And we've got Julia Brown, Service Director, Jill Nickerson, Head of Innovation and Delivery, Ian Lightley, are we all, and Andy Williams. So, Andy's, so it's just Andy, is it? Okay. And I understand, Julia, you're new to the team.
I am.
So welcome. I'm sure you're going to see a lot more of us throughout the year, but hopefully you'll settle in and everything will be fine. we won't give you no time, I promise.
Everything will be fine. Thank you very much.
We won't give you no time. Not at this point. Not today.
Next time.
Would you like me just to launch straight in? Yeah. Okay. I don't know if you'd prefer me to stop after each section. I've got 4 sections that I'm going to be speaking to today. We're going to start with Care Act assessments. Would you like me to take a pause in case there are any questions after each, or just plough through?
I think it would be really good after each bit, I think, because else it all gets a bit muddled. So yeah, that would be great. Thank you.
Okay, so the first part in the schedule for me is the Care Act assessments, of which we know that we're making really good progress on. Currently, to the data that we're reporting here, September's, we can see that you know, our Care Act assessment waiting list continues to improve to where we need it to be. We were at 301 at this point with a target of 200. But given that we were talking 800 a year and a half ago, it's been a significant piece of work that we've continued to plough into. Of particular importance in this space is the time that it takes us to complete an assessment, which is down at 16.9 days to complete an assessment for when it's allocated, which is a really good bit of work. And the number of Care Act assessments that have been completed in that period being 178. So we continue to see good progress there. I've put a note here to myself that whilst we've continued to do good work in this space, that we're starting to take a more targeted approach to support the system. So what we know is that clearing a lot of those assessment backlogs over the last 12 months has meant that we've seen an increase in the demand on things like dom care and residential care. So we're starting now to re-engage part of the budget containment plan for the council at what we can do to ensure that we're spending our money right, and whether or not some of those needs may have changed and we can review them. So that'll be part of the narrative that comes to subsequent scrutiny. I'll take a pause there in case there are any questions.
Andy?
So just to clarify, I mean, it's excellent work on getting these assessments done as promptly as you do. Can you just, sorry, I missed the point slightly. That advantage, how you will plough that back into the overall plan. So the savings you made there, the good work you've done there, how will that impact upon the rest of the operation, please?
Sorry, you'll probably need to just break that out a little bit more to me. So how will it, what financially?
You said that obviously you learned from the success you've had with reducing, doing the number of assessments and getting excellent results on that, which is commendable, and we as a committee are very proud. You went on further to say how you were then going to use that strength. Could you, that's the bit I missed.
Yes. So what we do is we set targets. We have internal governance where we meet with the local authority. We decide what's the priority for that month, and where we know that we're catching up with where we want to be, we then maybe deviate some of that workforce to look at other things that would be of better value. So if, for example, there's a priority around particular providers, if we know that we're concerned about a spend in a particular area, we can then think, right, okay, well, we'll readjust our figures, our targets for this, and we'll focus some of our capacity to ensure that we've got that extra level of assurance in another area. And that's exactly what's going on with the budget containment plan. Okay.
Will?
So you've got, it says sustainable waiting lists. I think you've just referred to it as 200.
Yes.
So how have you come to that? What's the methodology behind that figure? Is that, well, I'll let you answer.
So the reason we set the 200 as potentially the sustainable target, I mean, obviously it's a trajectory. So obviously a trajectory is always an assumption. What we understood is that on average every month, if we hit 200 character assessments every month, which when we were looking at setting some of the figures, that's what we were aiming for the team to achieve. So by having 200 in the waiting list unallocated, in theory, once you hit that number, you should be able to process each of those character assessments within a 28-day period, which is our overall target. So which is why we set 200 as the aim for a sustainable waiting list. Obviously, when we reach that point, there'll need to be an analysis of whether our assumption was correct, but that's how we reached that figure.
Thank you.
Is that okay, Will? Yeah. Anybody else? Alison.
So at the last scrutiny meeting, we talked about how many character assessments result in a package of care. And we were told it was around 20%. I think it was Ian was going to go away and come back with figures which would tell us how many community-based assessments, how many of those alone, not hospital discharge, just ones that come in from the community. Yeah. How many of those result in a formal package of care? Do you have that?
I don't have it to hand, but it's definitely something that we can pull. And it's I don't know if there's a facility to share with scrutiny and post this, but it's definitely something we can provide for you.
It'd be useful to see that, please, if possible.
I'll add it in for the next scrutiny report.
Brilliant, thank you.
Anybody else got any questions? Okay, if you want to carry on, Andy.
Okay, so in terms of Care Act reviews, we can see that our percentage of long-term service users with an assessment within the last year has risen to 57.4. It continues to show that there's some, again, good work going on in this area. The national target is 60.7, and I think within the recent month that's not shown here, we've continued to make that same level of progress. Despite the added responsibilities, the review productivity remains strong and in line with national averages. The most long-standing reviews are complete, so while further efficiencies may be limited, we're focused on reviewing new cases promptly, reducing waiting lists and delivering timely responses to care remain a top priority. This likely links is something that I didn't actually capture within the Care Act assessments, but in line with the work that we're doing here as well, there's behind the scenes a massive target upon the how long people wait as well. So when we see that there's an increase in the time that it takes, or not increase, a reduction in the time that it takes for someone to either receive their assessment or the review, those are improving in line with this work as well. And again, the same part here applies to reviews as it did Care Act assessments. We have a targeted team that have been working solidly on this piece of work, and that particular team is the team that we're going to start to refocus in terms of pressures.
Anybody got any questions on that? Ray?
I'm just looking at the trend for these waiting times.
Mhm.
It's got there from April 23 to September 25. Can we see like a climb there in that waiting time, or is that going up?
It's the numbers that we've done there, I think. So we've done 337 in that period. So that's the volume of the work that we're doing. So it's somewhat skewing that as well.
So the graph in this area is about capacity of work being undertaken.
Yeah.
So rather than the waiting time within a review, because they're different, so we anticipate that everybody should have a review every 12 months, but obviously some people require a review earlier than that. So it's quite difficult to map that sometimes. So what we try to look at here is the volume that as a Live Well are achieving within the review capacity team to ensure that that is continuing to move towards the regional target of 60% to be within the last 12 months.
Thank you. Thank you very much.
Could I just ask a question, please? With the regional target, who's actually set that target? Is it government, or is it Plymouth, or is it local health?
LGA.
Councillor Knight, I'll answer that one. The target we have set locally, but it's based on information that we see nationally in terms of performance of other. So we look at comparator authorities, and what we did, we looked at where our initial position was, and then we set ourselves a stretch target to get to a place to achieve, which is shown there. And that cycle is one we do annually. So we're about to start that process of thinking about what those targets will look like for next year in terms of expectations.
Thank you. Anybody else? Alison?
So I'm looking at the percentage of reviews with increased cost. So is that to do with the cost of the care, or is it because of increased need?
It's because of increased need. It's a knock-on effect of being more in touch and more in hand with our reviews. We become aware of changes of needs quicker.
Right. Okay, so another question from me.
Okay.
So have you got some data to show the number of reviews that have resulted in a reduction?
We capture that. I mean, I won't have it today,
or,
but definitely.
A remove, or a care package being stopped completely.
Yes, we would definitely have that. If it's something that you'd like added to the pack,
Yes,
we
please.
can do.
Yeah, I would. Yeah.
It's always of interest.
Yeah, because I mean, the care package it's not necessarily for life, is it? Things can change for.
Completely.
I can sort of think of sort of a number of circumstances why care wouldn't be needed anymore. For example, installation of equipment via occupational therapy, or
Yeah, you're completely right. It's an area of interest as we move forward, as well as we
I'd
become
really
more
like to see
digital,
that be-
as to the value of the changes that we're making.
Yeah, thank you. Oh, sorry.
Anybody else got any questions? No. You'd like to carry on, Andy?
Okay. The next part is occupational therapy, the minor adaptions part of this. So the number of people waiting for a Section 2 occupational therapy assessments reduced over recent months, but further work is needed to bring the waiting lists down. Live Well are engaged in an improvement programme which will formulate a clear recovery plan aligned to the wider transformation by proposing a shift towards early intervention and community-based support. Key initiatives include encouraging private equipment purchases for those without eligible needs, reintroducing services like care and repair, and better use of community hubs to reduce reliance on formal care. The plan also suggests raising the minor adaptation budget threshold and streamlining access to basic equipment through self-referral and partnerships with local suppliers, releasing capacity within the team to concentrate on the waiting list backlog. Essentially, what's happening within the world of occupational therapy is some of the learning that we've taken from the character assessments and reviews is being deployed into that space. Jill's been very instrumental in creating that link between PCC and Livewell, and Livewell have their own project board as well set up specifically for this, and we're hopeful that over coming months we'll start to see the same sort of improvements that we've achieved through CARAT waiting lists with occupational therapy. Section 2. Well, Section 2 is the DFG part of occupational therapy, minor adaptations. Ooh, that can be close.
Andy, I'm just reading here that the average waiting time is 192 days.
Yes.
That's really high.
It is really high, yes. Yeah, that's part and parcel of, so if we're trying to be transparent about this, so a lot of our data was held on one particular system, and the free flow of information between the two was problematic. So a few months ago now, this started to be challenged, and we started to see a better link into the data that's held on System 1, which is the health system where a lot of the integrated therapy data is held. It was only really at that point that we were able to start challenging and trying to differentiate between what a health occupational therapy waiting list might be and what a social care occupational therapy waiting list might be. Part of the difficulty is we're still essentially holding ourselves to account for all of it, but we're still now trying to work through what's the priority. So it isn't great that the waiting times are that long, but it is in that same way that we did with the character assessments, trying to engage with people to make sure that they're safe whilst they're on that waiting list, and trying to prioritise how we manage that, because sometimes you have to, the more urgent people won't necessarily be the longest waiters, and therefore it's a little bit of a chasing your own tail. But we're reasonably assured that we've got good sight on all of those now.
Can I ask, why is it so long? Is it because we haven't got enough staff?
Yes,
What is the reason? If we got
It would be really difficult for me to answer that one, honestly. I think there's a mix of things. I think the nature of what is occupational therapy is ever changing. The pressures, as well as the demand that we know clearly from the adult social care work that we pick up. But then also, yes, we're regularly fed back that from a workforce, from the time and flow exercises that we've done, that there are challenges in terms of the staff that we have available to do that.
I think, Councillor, it's just worth us thinking when those numbers are too high, and when we started our work around character assessments, actually, some of our longest waits were higher.
Yes, indeed.
Than that, and we did a lot of work to bring them down, and we put focus into that, and we learned quite a lot about that process and how to do it. Those principles, actually, we brought occupational therapy here, didn't we, for some of those conversations with Ian, were about, again, how one of the advantages of Plymouth is it can see its whole occupational therapy need versus just an adult social care need. That is a strength, but also we could see the size of that, and I think we'd seen representations from people around how long they were needing to wait. What we're starting to see now is that same methodology going in to the occupational therapy waiting list, so that we can hopefully achieve the same similar improvements over time. My experience of it normally is, as you get into that, it normally then looks a little worse before it gets better, because you get into your data, you do a lot of work to understand it, and then it starts to come down. That work's been happening through Livewell now.
Yeah.
So that whilst those weights are still high, you'll see there's a target now already to see them start to reduce, but we will then set another target through next year for them to continue to reduce. There are complex issues. Some of it is around the way you work. Some of it is about resourcing levels. Some of it's, so there's quite a lot of things to do there, but all of which our system learned a lot about when we went and did our Care Act work as well. So that's the methodology being applied. But I guess we would agree that the work is important and we need to see more demonstrable improvement in that area.
A part of that work is about looking at how we use the workforce as well, because obviously we have a responsibility to ensure that it's not just about how many staff we have, it's also that we're using the staff to the best effect. And we learnt a lot through the Care Act work that we did, and having Jill involved in the occupational therapy part of it as well will give us the ability to challenge that. And of course, we've got Julia now as well. So, and I know Julia is really keen to get a toe into that and check if it's heading in the right direction, and the problems that we see are as we see them and not systemic of something else.
So just to give you some assurance, what you'll notice with the waiting list, although the waiting list is starting to come down, it's not coming down as quickly as potentially we did in the care assessment. And it is because the team have started at the front door. So they're trying to ensure that people who are coming through, who have also been waiting a long time sometimes for advice and guidance, and they've been doing a lot of work around that. And so the transformation board, which potentially we can bring, I'll add that into the slide for you for the next scrutiny pack, it starts to show actually that work they've been doing in the front door to ensure that when people are approaching for a support and need, they're being directed into the right areas much more streamlined and quickly. And that has meant that the waiting list hasn't continued to grow, which it was previously to April. It was growing as well as not coming down. So the work they've been doing, although they're starting at the front door, it's so that we've given them time to actually align the data to ensure we had those phase targets in, to ensure that, because 150 days is still a long time. That's your phase 1 target, and in a couple of months that will then reduce down, and there are 4 phases over the next 12 months to try and bring them back into the aspirational goal of what we have already with Care Acts.
And what would be helpful, because I know like social housing, they won't put any adaptations in like rails until there's been an assessment, which isn't very helpful, because obviously that takes time also. I mean, it would be quite helpful if the housing associations, if it was just like a handrail at the front door or in the bathroom, if they'd done that, that would actually help reduce that time. I mean, I can see your point, but also I think, I don't know if there is anything that we can do with the housing associations when it's something minor, like just a handrail here and a handrail there, whether we could do something as a local authority to say, look, just put it in, it doesn't really matter, it's a handrail. That would maybe start to reduce those lists for you too. I don't know, maybe that's a recommendation we put through. I don't know, that we speak to housing associations to see if it's something minor, that they wouldn't have to have a occupational therapist to come out and put a report in.
I think it's a really good idea. I'm not close enough to the detail to know if there's a more complicated process that people have to go through at the moment, but I think that we're at that point where we'd welcome any suggestions, and it's definitely worth exploring.
Yeah, I was just looking at the figures for July and August. They're quite high, aren't they? And I was just wondering, it would be valuable to see last year's figures and are we improving year on year? That would be a great thing to see. And then we could maybe see if it's a seasonal issue, staff holidays, things like that. People are more sicker in the summer, things like that.
So with the OT data, the reason you are unable to see before was because we had 2 systems and the information was not clear, and we had no, what I would call, single version of the truth. We had very varying ideas of what the waiting list looked like. So the reason the data starts from May is because that's the point where we had a very clear understanding of what the waiting list was and how we were going to move forward. We do have data available which we can pull and extrapolate, but it might look slightly disproportionate because it wasn't in alignment with the new methodology that we're using. So I could do a once-off kind of data understanding so we can see that trend.
You've probably just answered with what you've just said. So there's this both page 22 and 23 there, which is the section 2 and section 9 data. You've got this increase between May and June of the longest wait. So is this due to you changing because it's gone up from 459 to 557, where it's only 30 days between the 2 dates. So
yeah,
is this where you've sort of gone through and found, or somehow somebody's gone on to back onto a list or what have you.
It's where we went from having the two systems to the one. So this is where we had Eclipse data and System 1 waiting lists, and it's where the team amalgamated the two into the one system. So currently this is all held now on System 1, which is why we have the accurate picture. But that's exactly right. That's where you saw that quite a big increase in the longest waiter is because that person was moved into the System 1 data, so we had one clear visibility.
And what's the distribution of the, because obviously if you have, you know, some people at the very high end with very, very high numbers, that could pull the mean up, or what's the distribution of people? I think looking back from previous slides, because this has come through a couple of times, we've had sessions, there was like sets of people who sit, cohorts of people that were different in different sorts of bands. If you banded it, you know, people are between 100 and 200 days. And
do you mean risk, or do you mean time scales to complete an assessment? Sorry.
The time scales, the waiting. I mean, they did talk about before about having like a you know, almost doing a red, amber, green. So you were prioritising the high need people, the people that needed it more urgently. That was a
completely.
Kind of
so
organise it so you were tackling people that had the highest need, and then find alternatives maybe for people that didn't. But
sorry, go on, Gary.
Sorry, Councillor Noble, just to say, this is our standard performance report, which looks at our headline metrics. I know what we have done is come here and shared more detail in therapy, but I think this report, we do have all that information around the people we prioritise, the ones that we don't want to wait, that won't wait. But what we don't have, we don't put all of the information in all our reports because they get quite deep. So this is our kind of overview performance report that we bring here on a more regular basis. We are very happy, and I know we are happy to come back with much more detailed information on any area subject to scrutiny agendas. That's fine, but I think we don't typically have that information in this report for our regular monthly briefing.
Can I just ask, because I know that when people are sometimes waiting for occupational therapist assessment, when they phone up and ask, or somebody asks, they get told that they can actually pay privately for occupational therapist assessment. So with that, do we know how many people actually pay for a private assessment?
No, we wouldn't, unless they informed us that it'd be a really difficult thing to track if people independently source things. We know that that's probably been a more frequently used bit of advice, especially when we know that we've been under pressure with available equipment in the system. But generally speaking, it's good practice wherever we can to signpost people to alternatives to if a full assessment's not required. But I would, the caveat to that is that our front door team are very good at being able to differentiate between what would appear to be someone that needs a full assessment and those people that might be appropriate to signpost. And it's never a you shouldn't call us, you can go and buy this. It would always be a tell us about what your needs are, describe to us what the picture is there. That's what it should be.
That's what it should be.
Yes.
Yes. You're absolutely right. That's what it should be. Whether that's what's being said is a different matter, I'm afraid. Okay. Anybody else got any questions on Ray?
I'd find it useful in anything like this to see what the cancer wait times are from start to finish.
Yeah.
Because it's being brought up in the media all the time, and it'd be nice to be able to answer people's questions.
I think if we don't have that here, then that's definitely something that we can do. It's something that we aim to do with the character assessments as well. It's not just the how long are people waiting at the moment; it's the whole journey picture. So we can do that.
Anybody else? No. you want to carry on? Andy? Thank you.
So the last slide for me is again, it's a very similar part of occupational therapy. This is for individuals that are already receiving care but require assessment for adaptations, equipment or rehabilitation under Section 9 of the Care Act. There's an overall improvement in this area which continues into October and November data. We can see again that our unallocated list is going down. The target that we'd set for this one was 103, and as we grow closer to that, we'll review that to ensure that that practice continues. Longest waiter is 588 days at the moment. In September, I'm hopeful that one's gone down as well, and a mean wait of 192. The bit of narrative that I've got here is that we consider there's opportunities to include phasing out non-essential evidence provision, introducing online financial screening prior to disabled facilities grants, assessments, and developing integrated teams to improve throughput and reduce duplication. The plan also supports the use of video assessments for housing suitability and explores accreditation for non-occupational therapy staff to prescribe equipment. These steps aim to ensure assessments are timely, targeted and legally compliant, and without wanting to overgo the bits that I've just said, this part as well is subject to the same improvement plan that the Section 2 part of occupational therapy is.
Everybody happy? Yeah. Okay. Thank you, Andy.
So I'm just now going to take you through to our commission services. So at the moment, we've seen, as mentioned in the budget update, we've seen an increased pressure into the residential and nursing care packages that have been requested. What you will notice is that obviously the cumulative figures around adults over the age of 65 in October last year was around 368, and at the moment we're sitting at around 391, so that is over where we were last year, so that is a significant increase. Whilst the overall we can see that there has been a fluctuation throughout the year, this has steadily now re-increased to where those numbers we saw last year. So those pressures that we're feeling around additional care support needs for residential nursing and for nursing care has increased, and it will continue to be a budget pressure. At the moment there is lots of work that is happening across adult social care to review packages of care to ensure people who are potentially coming out of hospital, who might be going into a nursing care placement, to just ensure that actually if things are improving that we can step care down, etc. So that's some of the work that Andy and the team will be doing around reviews to ensure that people are receiving the right care packages that they require at this time. Sorry.
Anyone got any questions?
So if somebody is placed in residential care by hospital team, how soon are they seen by, I suppose it's a community team, sort of as a follow-up to see whether they need that ongoing level of care or whether their care could be managed at home?
They're seen or contacted within 24 hours. For people in the community, we like to respond in person within 24 hours. For people within a residential provision, we usually call the provision first and then would see them within 48 hours.
A further follow-up sort of after so many weeks or something to give that person time to
100%.
for a further kind of
I've got my colleagues from the
recovery or
ICB behind me, so I can say nothing short of.
Yeah.
We get out there as soon as we can. We're actually aiming to work towards. I think it's Ed. What's our target for pathway 2 at the moment? 42 days. So from start to end, 42 days from the time that someone arrives in a residential provision to when we would hope that journey would be a long-term one and resolved. But obviously within that, we don't sit and wait until 42 days. If we can get people home sooner, then that's entirely within our aspirations, and we do.
Sorry, can I just ask? Obviously, you just talked about when they go into residential care, and so before we can get them home, do we encourage these people that we're putting into these residential homes, because obviously they do want to go home and they want to look after themselves? Are we encouraged when they're in residential care? Are we encouraging them to be able to do stuff for themselves, or are the care staff doing everything for them. So giving them the medication if they need medication, making them their meals and all of that sort of stuff, because that is all part of it, because they need to be able to look after themselves when they go home. So if we put them into residential care and then everything's getting done from, and they're maybe in there for, I don't know, 4, 6 weeks or whatever, how long it takes, that's 6 weeks of them not being independent. So that worries me, that we need to make sure we encourage people to be able to fend for themselves if they are capable of going home.
Completely. So it's really difficult because nowadays the threshold for someone requiring residential care from following an acute admission is quite high. So wherever there is a possibility that it looks like people might be able to go home with support, then we would probably encourage them on our pathway 1 and put a robust package around them. For those people that do then subsequently go into residential care, we are continuing to work with the ICB. We have some plans that are coming up to look at whether or not we can fast track some of those people that are likely to go home with appropriate support. Not that we're saying that we don't do that anyway, it's just that we have a finite resource and we target it as best as we can, but we're always looking at ensuring that those people that even have a whiff of possibility of being able to return home, that's entirely the priority, and those people will probably be the people that have our occupational therapist team in the care home trying to support them back as well.
Can I just ask as well, because obviously most of the residential care homes have people with dementia.
Yes.
And it's, some of them have got really, high-end dementia, and then we discharge people from hospital that just need to go into that residential care, into a residential care home just for a little bit, but they haven't got dementia. So we've got this person that might not have dementia, but we're actually putting them into a residential home with 9 times out of 10, most of those people that are long stay people in these places have got dementia. How does that fare? Because this person who probably doesn't understand that that person next door to him has got dementia and can't communicate how they would be. So for me, that you're putting that person into some sort of isolation because they can't have because there would be no contact, because that person there and that person there doesn't understand that that person's got dementia. And it just, have we got any care homes? So what I'm trying to say is, have we got any residential care homes across the city that hasn't got people with dementia in, that we could actually put people coming out of hospital that need just that little bit of care before they go home? Have we got that?
We do have providers in the city that take people that wouldn't be cognitively impaired, shall we say, but they're very few, because the push nationally is if you can, you should be at home. And that's where the majority of the focus nationally and locally has been driven. But it's also really difficult because, I would expect, and I'm speaking a little bit anecdotally here now, that the people that can afford to provide for themselves in residential care, some of those homes will probably be more taken up through people that can fund their own residential care. It's not to say that we don't. Every individual that's discharged should be discharged to a place that's appropriate to their needs. And if their needs don't suggest that they need complex dementia care, then the first priority that would be to try to source someone who a home that doesn't have that. I've got 2 people on my side here, so.
Thanks, sorry, so just
He's going to say what I'm going to say. Carry on.
just to add, from a commissioning perspective, we're doing quite a lot of work at the minute to look at the beds that we're buying for people who are on intermediate care, and we've got an enhanced specification that we're working with the market on at the minute that has exactly that ethos of how is it that we can embed that reablement approach, how do we make sure that people aren't sat in bed, sat in their rooms, how they got up, how they supported to maintain those skills and to redevelop those skills that enable them to get back home again. And as Andy says, we've got a variety of homes across the city, some that are dementia specialists, some that aren't, but absolutely we will work to try and make sure that we map the person to the right appropriate setting. Overall, though, as Andy says, the priority is to get people home, but we know there always will be a cohort of individuals who need that bed place for a period of time, but it's about how we make sure that it's the right sort of support for them.
The only reason I'm saying this, Chris, is because I know that people that have had, who are in Derriford that are on the stroke ward, they have really, really good rehabilitation actually within that ward. So they've got like a kitchen there, they've got other means that they can do to help them on that road to go home. So I'm just wondering if we could implement that maybe at the start of the hospital, so those people that maybe need that little bit of care before they go home can actually use a kitchen and make themselves a cup of tea or a sandwich, or be able to take their own medication. Because I personally, and I'm sure other people have had personal experience of this, that if we don't do that, what happens as a person gets to a certain age, they actually give up, and they don't want to be doing stuff for themselves anymore. They're relying on that person to do their, and maybe somebody to do their wash and give them their medication. So if we can do that with people that have had strokes or whatever, could we not do that within the NHS in hospital for people of a certain age, so that we could do that with them before we sent them home? I'm just...
No, it's a really good point. And so obviously our priority, if people are in that position that they're able to start that journey, is to get them out of the hospital setting. And that's our part of our commissioning plan, is how do we make sure that the homes, as well as that ethos of reablement, that have got the right environment. So there's a few homes within the city who have those kinds of facilities around kitchens that people can go and relearn those skills and practice that as part of their reablement, special stairs and things like that in order to keep those skills. So absolutely, as you described, Councillor Smith, but our focus is how do we get them out of hospital, because that isn't necessarily the right setting for them in that scenario, but absolutely build on that kind of work.
I apologise if I've got this wrong, but I was looking at the target figure of 594, and that's a mix of residential and nursing, is it? Yeah? Yeah, so when you add the two figures up below, that you're actually 959, is that correct? Because that's the two different ones, isn't it?
Yeah, so the one at the top is cumulative, so that's what we set at the initial budget position, and then obviously we track as we go through the year with the split, which I think was a request a few scrutinies before, to understand number of people who are going into nursing care and the number of people going to residential care, because obviously they're two different approaches.
So at the moment we're 959 when the target is 594, that's correct?
Yes. Yeah.
So I would like to know really if you could feed back to us, have you any ideas how we can improve things to get to that target? Are people being released too early from hospital that they're needing the care, or is there something you could feed back from the ground to us, how we could improve that target? Because that is a marked increase on the target, isn't it?
Can I, Councillor, the top number is a proportion per 100,000. So that's not, the bottom numbers are real figures. So that's why they look different, because one is expressed, because when we do our returns, and that's one of our statutory returns, you compare by population per 100,000. So it's a number that's used and aggregated to 100,000 population. The bottom numbers are the actual numbers of people, if that makes sense.
Are we at target then?
Say again?
Are we at target?
So we're not at target, because
No,
we're not at target.
Okay.
So I'm agreeing with you there, but what I'm trying to do is just confirm the numbers aren't adding up. So one is a ratio target and one is a raw numbers target.
So it would be good to get some feedback on, is there anything we can do and that to help to get to target? I'm looking at the figures. I wonder if people are being released too early from hospital to free up beds. That's my worry.
Yeah, well, I've started it. I haven't been here very long, but I have started a piece of work with our hospital teams to look at the number of people coming out of hospital and ending up in a bedded setting, and whether that's too soon. Are we targeting their care assessment soon enough to ensure that they get the least restrictive option and the opportunity to return home? So that is an area of work that we're working collaboratively across our system to try and understand.
Has anybody else got any questions? No? Roy, we did put...
When we were talking about reablement and we were looking at our occupational therapy weights, my concern was obviously people going into residential care, needing occupational therapy when we already know we've got a problem. That was my concern.
Okay, do you want to carry on?
So then we're moving into domiciliary care. So obviously there is an increased pressure with obviously the 824k current budget pressure, predominantly coming again because we're talking of home first. So this is so that people can be supported in their own homes. We're working closely at the moment with Independence at Home to try and increase capacity for coming out of hospital. There's also lots of work with our internal brokerage team to try and ensure that that's timely and people are giving a choice when we're offering packages of care so that people actually are able to continue living independently at home but also live a normal ordinary life in line with where they feel is best for them. So there's lots of conversations around that happening. But there is a steady increase within requests for domiciliary care packages happening, and so there's lots of work in the background happening at the moment to look and understand why, and is this a change in need into our market. So we are working with market providers along with the ICB to look at actually how we can increase our capacity in this area, because we believe as we move forward continuously we will start to see more people wanting to go home first, and that links in with the NHS neighbourhoods at home.
Yeah. To be fair, that's really good that we've got people wanting to well, being at home with a care package. So, you know, that's far better, to be honest. But then a care home. But actually, I want to go in a care home. I want people to do stuff for me. Has anybody else got any questions?
So I'll move then into reablement, which is obviously for people who are coming home. So this is something, again, that we monitor. So it's around people over the age of 65 remaining home after they've come out of hospital following 91 days. So we track how well we're doing the reablement service. At the moment, we're sitting at 81.6%, slightly above the regional target where we look against our partners. And the number of packages has also continuously increased, which is really positive. So we're starting to see more and more people come into the reablement service. Our average length of time within reablement is sitting at 4.7 weeks, and we have a target of most people to be returning to a normal life within 6 weeks. So again, a really positive story for us within what we're offering in this area. We want to increase our reablement offer across the city. So within the transformation programme, we are starting to look at how we can improve our offer of service and encourage more people into this area when it's appropriate.
Just a quick one on that. With the amount of more people having a care package at home and being at home, are we confident and that we've got staff that'll be like care staff to be able to cope with the numbers? Because obviously, with all due respect, it isn't our job and it's not a very well paid job. So my concern is that we've got all of these people, which is absolutely brilliant, people being able to live at home and stay at home longer, but will we be able to provide them with the care packages? Will we have the staff to be able to do that?
We do a lot of work in our system and you'll be aware, Pauline, of a period just post-pandemic where that became as difficult as I think I ever remember it. Having said that, I think a lot of the work that the system has done has helped us really build some of that capacity back in. There's always a healthy tension between need and availability of staff, because for organisations you've got to earn money by working. But I think for us, we're seeing a market that's recovered relatively well, and at this point in terms of our winter planning and our engagements with the market around recruitment, there's certainly interest for people in terms of getting employment in this area, and we absolutely, we're going to maximise that benefit, because while it's there, because it's really important, isn't it, that we grow this area of our market and we invest in trying to keep people at home and supported there if that's what they need. But the market at the moment is holding and recruiting well for us.
Yeah, I mean that's great to hear. Because I know at one point, you know, there was a concern that people didn't want to go into that sort of profession. So no, that's absolutely great. Yes, Melvin.
It's important as well to have that continuity of care, isn't it, where the carer actually knows the resident, because then they will get better quicker. Having somebody who understands their needs and can look for those discrete changes if things aren't right.
You're absolutely right.
Moving on then to direct payments. So the reason we bring direct payments here is because obviously this is again for people's choice. So we try to encourage around 20% of our current users to be utilising direct payments, as they're able to then purchase the services for themselves within what fits their lives. I'm really pleased to actually say that we've actually returned to above the target of what we set for this year, which is 635 people. That's over 20% of our current users. We have now brought the banking service in-house, and there's been lots of work with Live Well social workers to encourage direct payments for people, and we're going to hopefully continue to see that grow. Yeah, that's direct payments.
Anybody got any questions on that?
Are there any particular challenges with direct payments? Because, I mean, the numbers, I mean, are they considered a bit low? The kind of the uptake for direct payments, and people sort of choosing commission services instead? And are there any, you know, issues that are sort of stopping these from happening?
Sorry, Councillor, I'll answer that only in as much to say, whilst our numbers dropped a little, we were actually considered to be a very strong performer in terms of how we benchmarked with other authorities in terms of our numbers. So our numbers are actually reasonably good. Having said that, we did not want the numbers to drop the way they did. So we've certainly put focus through the end of this year in getting those numbers back up, because we know it's good for people. We actually know it's good for us as well, but it's good for choice and it's good for people's control. And so we are now promoting and pushing, and I think when we set our targets again for next year, you'll see us try to stretch that target to further improve it. But actually our numbers still, whilst we weren't in that top quartile of performance where we are still performing relatively well compared to others, but we want to get better at that.
Anybody else? No.
Okay, last slide, which is around our P1 performance at the hospital. And seeing as Chris is sat beside me, I may look this way, is around our no criteria to reside. So obviously there is a hospital ward improvement plan, which has got an increased focus around planning the discharge with using better resources. And I know that Ed and Chris will be talking to you a bit more about the winter plan, so they will be able to go into a little bit more around the work that has been happening with P1 pathway to improve our hospital discharge.
Thank you very much. Anybody got any questions? No. Oh, go on, Will.
So I've just closed the. So is this within is the no criteria to reside? Is that within the sort of the targets? Because obviously this is a bit where it links between the hospital and the patient flow and etc. etc. So is that? Because I don't. It says 9%. It's quite difficult to read. I try to read what's our performance.
See that.
It's quite difficult to read there.
It's it's complicated in, obviously, for Derriford Hospital, it discharges into 3 local authority areas, so Devon, County Council, Plymouth and Cornwall. We have, over the last few months, seen an increase in the no criteria to reside position. It has been above the target that we agreed with the hospital for the year. However, in recent weeks, that has dropped back down again, and certainly for Plymouth, for people who are on complex discharge, so pathway 1 to 3, which are those that need some additional support, we've been back down at about 5 or 6%, which is our target and benchmarks really, really high nationally as well. There's more work that we do, and actually we had a meeting this morning with Devon and Cornwall colleagues as well to talk about the actions that they're undertaking, recognising we'll be talking shortly about the winter plan, but absolutely making sure that we bring that number down and hold that through winter. But it's very much collective work between ourselves, Live Well, the local authority in order to do that. But as I say, definitely the position has certainly improved over the graph that you can see there.
Can I just say thank you all for your reports? If we can see that each time that you bring a report, it is improving. So all we can say to that is well done to all of you for trying to meet those targets. So just keep up the good work. You're doing an amazing job. So thank you very much. Thank you. Sorry. Oh, Alison. Sorry.
Yeah, just a comment on the last report. I sort of had to do quite a lot of Googling to understand the jargon. It's quite hard to understand unless you're in the field, doctor or nurse or hospital worker. So just that bit of feedback really from me. Just say it could be clearer.
No, that's absolutely fine. If you can just, rather than just using short word, can you just make sure that it's the full, so that everybody understands what it is? Thank you.
I'll try to improve that next time.
Thank you. Yeah.
Thank you. Well, thank you all very much. Thank you.
There was a table at the beginning. Right, several times several.
So we've got item 7, which is winter planning. We've got Michael Whitcomb, Deputy Chief Operating Officer, UHP, Louise Ford, Head of Commissioning, and Ed Garvey, Head of Locality Commissioning. And Chris, who we're probably going to see a lot more of.
Okay, so thank you, Chair. So we've obviously this is part of an annual process that we go through in terms of our winter planning approach. So this is something we do annually, and actually it's probably the 4th or 5th time that I've been to talk to you about this. It's a collective effort that we go through across University Hospitals Plymouth, Live Well, the council, ourselves, and also all the partners that we work with. What we do in terms of the approach, we get guidance each year that comes out that helps guide us. There's returns that we have to provide to NHS England in terms of the approach that we're taking. And all of the work that we do is built on analysis in terms of what we expect the position to look like over winter, what we expect the demand to increase by, the analysis that goes into learning from the winter sickness, flu season, particularly in the Southern Hemisphere, so what's happened in Australia and other parts of the Southern Hemisphere, in order to develop a predictive model that describes what we're anticipating. So the slides that we'll take you through today, Michael will take you through the position in terms of the hospital and the work that they've done. These were slides that we presented to the Health and Wellbeing Board recently, but as we go through, we'll be able to give you an update in terms of the current position, what it's looking like, and the actions that we're doing. Louise will talk to you about some of the activity that's being driven through the social care market and working with partners within the community. Ed can give you an overview of some of the work as well around the additional demand to help with that hospital discharge position. I'll give an update as well around the vaccination programme, but I'll hand over to Michael first of all.
Hello and good afternoon. So as you can see from the slide pack, which is quite extensive, I do apologise for the multiple slides, but it sets the scene by obviously acknowledging our familiar seasonal pressure. So respiratory illness surges, high bed occupancy, long emergency department waits, ambulance handover delays, etc., and where we were at for the last winter, and setting out the scene for some of the actions we are taking within the winter plan, using the national expectations as the backbone of the plan to improve our category 2 response times that we support with SWAST, and our handover ambulances within the time frame of less than 30 minutes is our aim to support with that, and working effectively across the system partners and community to provide a comprehensive response to keeping our patients and staff, more importantly as well, safe during the winter period. So the summary of the operational picture, just moving a couple of slides through. Ed, I believe, or Chris, sorry, I've forgotten who's got control. Apologies for that, skipping through on the slides. So that's the summary at the beginning, and we'll move to the next slide if that's all right, please. So we're taking a system approach, as I've said. There's 7 key areas of work streams that the teams have been developing on. Without any mitigation, at our worst point, we would have 70 to 90 beds, less than 70 to 90 beds to work against the demand. And that doesn't include our pre-hospital emergency queue as well. So that's the number of patients requiring a bed for admission moving into the hospital from our emergency department. With our one plan strategic objective, it brings us down at a 50% delivery to a minus 39 bed gap. And some of the actions that we've taken has reduced that bed gap further, which I'll take you through. Next slide, please. Those are our objectives, as I've mentioned. For the ambulance target, we do need to see our ambulances offloaded within the 30 minutes, and that's the slight deviation, but the backstop is 45 minutes. And obviously we are focusing heavily on our vaccination programme and rollout. Next slide, please. Just a bit of a performance summary. I know that this isn't most recently up to date from the last iteration for the Health and Wellbeing Board that we brought to you previously. However, I can confirm there was quite a significant deterioration in our ambulance handover performance within October. However, this has been clawed back now, and we've responded effectively with less than 1,000 hours lost of ambulance handover delays, just to give you some of the focused and attention that the hospital is taking on this, and how serious and committed we remain to improving our UEC access to the hospital. Next slide. So we have the key assumptions that we will see a non-elective demand increase of 1.5%. The peak flu and COVID will happen the second week after Christmas. So as we come through, and you'll notice within the rest of the slide pack that the UKHSA and the guidelines around the numbers and the mapping of the pre-hospital setting and actually the impact to the hospital when those patients come in. No criteria to reside we've talked about already at the targets, and I'll let Chris and Ed speak to that through. But we are maintaining our elective services to ensure that patients are receiving their care timely. We're not standing anything down in anticipation of response, and we are working collectively with the virtual wards and our community partners to get our patients to the right place at the right time and discharged safely at the right time as well. Next slide, please. So as I mentioned before, we can go through these slides as I'm talking just gently, but it shows you the model demand flu from Australia and our flu vaccine uptake comparison by age group, just to kind of give you some of the scientific method around what we're anticipating. This slide, more importantly, we lost around 120 beds occupied due to flu and COVID and also norovirus during the period that we've just talked about around the second week after Christmas, and that's where we're focusing on. Within that, the care home cohort of those patients accounted around about 10% of those beds. So we're focusing how we can bring our patients the care and the safety that they need within their residential setting, and providing them that care within the community rather than bringing them to the hospital, which puts them further at risk of harm and other hospital-acquired infections. So as mentioned, we're taking some actions and mitigations across both Live Well, One Devon, the local authority and the hospital to jointly meet the government's objective of a hospital to community. And as I mentioned, 7 key work streams. We can then focus on our IP&C controls, our community services, how we're responding to surge in demand and the timely hospital discharge, and some elements of our workforce and wellbeing as well. Carrying on through. So some of the key actions that are being taken are there. I'll take them as read, and moving forward to our rest of the slides is the vaccination uptake. Currently, we're about 38% of our workforce that's taken a uptake on our vaccination. Just to bring you an updated number on that. We do maintain a control and focus communications in particular, and almost you can't get through without being questioned around whether if you've had a vaccine when you're entering the hospital site, and particularly within our exit strategies as well. So we are also looking at some of the actions around how we can bring the vaccination to our hard to reach areas and working with the local authority and Live Well colleagues, and also our transport offer at our most peak times to ensure timely discharge. You can move to the next slide, please. Thank you. So in summary, there's a lot of work that is ongoing within the hospital to ensure that we are delivering safe and effective care. At this moment, our most recent up-to-bed demand and capacity modelling has deteriorated slightly. So where we'd mitigated to a -30 to 21 bed state, we're now at probably -33 to -40. However, there are UEC and elective recovery actions that we're taking jointly with the community to improve our virtual ward offer, reduce the occupancy of our beds, and make sure that we are robust enough in our approach to dealing with the surge of demand coming up through winter. And that I'll hand back over to Ed and Chris.
Thanks, Michael. Good afternoon, everyone. So I'm just going to talk to you a bit about some of the actions we're taking from a commissioning perspective, which is obviously a key part of our winter plan, working closely with all of the system partners in Plymouth to ensure we've got that resilience to support people coming home from hospital when they need it. So in terms of the approach that we take, and we've touched a bit on some of this already today, is by making sure that we understand and have a clear picture of the breadth of services that we've got within the system, and then match that up against a detailed demand and capacity analysis to ensure that our services can respond to the anticipated surge that we predict as we move through winter. And all of this is about ensuring that we've got the right care in the right time and in the right space for those individuals and patients upon when it comes appropriate for them to be discharged from hospital. So what I'm going to do is I'm going to talk to you about some of the pathway 1 actions, so the people coming home from hospital, and also touch on some of the actions around pathway 2, and I'll talk to you about how then we work as a system to ensure we've got the flow we need on a timely basis, daily and or on a sort of a monthly basis, ensure that we're all joined up in that approach. So from a pathway 1 perspective for Plymouth, we've maintained our ICB commissioned additional pathway 1 support for winter. So that's additional capacity focused on ensuring we can get people home and deliver the care for them in their own homes and when it's appropriate. We've also worked really closely alongside the Plymouth City Council commissioning team to ensure we maximise capacity for PCC's Independence at Home reablement service, which we talked about a bit today. And as part of that, in terms of ensuring we've got that resilience for winter, we've helped secure some additional agency capacity for that service through winter to ensure that we've got enough capacity to respond to surge from a pathway 1 perspective. Alongside this as well, we again work very closely with the local authority and our council commissioning colleagues to ensure that our brokerage processes are effective and can respond in order to get timely access for people that need domiciliary care, either off the back end of intermediate care services when people come out of hospital, or also in terms of that step-up response in the community when it's required. And it's important to note that as part of our approach for winter planning, that although we don't just focus on discharge, we also focus on making sure that we've got timely responsive services in place to respond to people in crisis in the community as well. So where there are opportunities to prevent hospital admission, it's about making sure that our wraparound services alongside Live Well in the community offer from a domiciliary care perspective and reablement perspective are available to support our patients in the community. So if we find that there are plentiful opportunities to support people in their own home and prevent an admission to hospital, which means they can recover much quicker. It's probably worth noting that in terms of the providers, obviously our providers across the city play a really important part, and they're integral to our relationships. They're integral to ensuring that we've got that resilience. So in order to support this, we've been having a series of workshops with our dom care providers in recent weeks to look at how we can grow the existing dom care workforce for people with long-term needs. And it's worth noting that has been really successful. So a lot of providers responded really positively in that space. They're really keen to recruit and bring on the additional capacity needed to support people through winter. And we've got capacity that's come online over the recent couple of weeks, but also commitments from our providers as well to bring on additional capacity up until Christmas as well. And obviously we know that the period a couple of weeks before Christmas and also as we move through January, always a really difficult time for hospital discharge, don't we, in terms of that increased demand, increased sickness in the workforce. So obviously that tends to mean that providers aren't always able to help us in the way that they do at other times. So the additional capacity that we've procured as we move through this period for Pathway 1 will help us get through that challenging period to make sure we've got the right capacity we need. And you'll all be aware, all councillors will be aware that we've really driven our focus on home first over the past 2 years, so that focus on having a home first approach to ensure people can live healthy, independent lives in their own home rather than being reliant on the long-term care market from a bedded perspective. So I think current data is we're about 66% of our complex discharges, so people coming out on a Pathway 1, 2 or 3 package following a stay in hospital or going out home now. I think our baseline started in sort of 24, 25%. So we've seen a real increase in that area. I'm happy to take some questions at the end. So that sort of covers off our Pathway 1 approach. In terms of Pathway 2, obviously these are people going into care homes. So we've worked again really closely alongside Plymouth City Council to ensure we have the right capacity to support people who need to go into a bedded setting with that right reablement wraparound for them. And we've also been working with PCC colleagues to understand the outcomes for those individuals and our support offer and focusing on getting these individuals home as soon as possible. So one of the pieces of projects we've been working on and Andy who was here earlier, is to look at how we can utilise some of the additional P1 capacity that we've purchased for winter to have a specific focus on supporting discharge people coming out of a bedded setting, recognising they may have some enhanced needs that we need to ensure they've got the right community wraparound and MDT support from LiveWell and our wider community services in that space. So that's a really exciting project in terms of putting some additional focus in that space. And in terms of how we work together as a system, so in terms of individual patients, so we're recognising there will be patients that perhaps have some more challenges in terms of making sure we can get them out on a timely basis from hospital. We have a daily system escalation call in place, which does focus on individual patients, alongside a system oversight arrangement across the whole of Devon to ensure that partners can respond to any escalations that occur. And we've also established very recently a weekly commissioning oversight group for Plymouth Commissioning Oversight Group, which brings together ourselves and also the local authority commissioning team to ensure we're monitoring any pressures that are building within the market that may impact hospital discharge, and in turn making appropriate rapid actions where necessary to support the resilience of the market and also our patients as we move through winter. So all of that describes at a high level how we ensure we've got the right capacity in place to complement our approach to the winter plan. And Louise is now going to take you through an overview of the actions that we have in place to ensure we have resilience within our existing dom care and care home providers through the winter period. Thank you.
Thank you, Ed. Good afternoon, everyone. Lou Ford, Head of Commissioning. So just really to kind of complement what Michael and Ed have talked about in terms of the robustness of the market, maintaining that flow during this critical period and ensuring the safety and effective care of our residents. Across social care, we have a number of measures in place, working with our providers, targeted community interventions to ensure that we can be responsive during these seasonal pressures. So one of the key activities for us around our provider market is ensuring that where possible, all eligible groups via those community providers are having vaccinations and that we are actively promoting those vaccinations. But alongside that, raising the awareness around the infection prevention and the control measures so that across those care settings, we are working really hard to reduce the risk of infection. And we have these conversations on a regular basis with our providers. As Ed has mentioned, some of the dom care work that we've been doing recently with providers, but we also have regular forums, and our next one in a couple of weeks' time, we will again be reiterating some of these messages around vaccination and infection prevention. One of the other areas that we look very much at during this time is the business continuity and the demand and capacity plans that we have across our commissioning service, but also with our providers, keeping a really close eye on the capacity that we have in the market, both for bedded care, but also for domiciliary care, and supporting, some of our service users to access the right funding where they can around household support, to assist with carers during the winter pressures period as well. And finally, one of the other areas that we really do focus in on is particular challenges for staff, training and education to help them with those discharge planning to ensure that those completion of timely discharge assessments. So thank you, and I'll move on. Don't know who I'm moving back to, Chris.
Back to me. Thanks, Lou. So just to give you a quick overview, there's some slides in the pack that describe the approach that we're taking around vaccinations for this year. So we've obviously covered bits of this as we've gone through the presentation today. Vaccinations are absolutely key, really important in terms of making sure that the population can protect themselves, protect those that they're caring for, ensure that resilience of the workforce who are supporting individuals. And as Michael described, the impact of flu, COVID, RSV and other illnesses has on the bed base that we have. So you can see there are three core areas in terms of eligibility and different eligibility cohorts, people who can access those vaccinations. We're in the midst of our autumn-winter campaign at the moment, as you can see, so it's well underway. The offer itself's open until the end of March, but there are different points as we go through that where different cohorts within the population have been supported to access those vaccinations. We develop our approach to the vaccination programme across Devon and alongside partners to make sure that we build on and learn from previous years and have a really, really good spread of opportunities for people to go and access those vaccinations. As you can see on the list, there's a whole range of things across GP practices, community pharmacy, work with schools, work with hospitals, and targeted offers to go out into the communities to support those individuals who are housebound, and then specific clinics that are developed and identified across Devon to target underserved populations and communities. As you can see, a whole raft of different focuses depending on the groups it's really targeted and built on. The communications approach that we develop, and this is done across all partners within the system, focuses on how we can make sure we learn from what's worked well, what people have responded to in previous years. The position as it stands at the moment, so the uptake of the vaccinations, particularly flu vaccination across Devon, has been really, really good this year. And actually when we compare ourselves to last year, it's quite positive. There are areas that we then, through looking at the data, identify where that might not be where it needs to be, and then we can support additional action in order to describe that. Michael obviously spoke earlier about the work that UHP have done, but Live Well too have had a real focus, and actually Live Well are tracking really high in terms of uptake within their staff this year when we compare that to across the patch. The message overall, though, is that we want to encourage people to help protect themselves, help protect those that they care for, by making sure that they take up the opportunities around vaccinations. The communication message this week, as we're in the run-up to Christmas now, shifts to that message of don't give the gift of flu for Christmas, and it's really, really important that people hear that and do all that they can. In terms of accessing vaccinations themselves, people can go onto the website, the NHS website, and search for the flu vaccine, and it gives them a link to be able to book in. It tells you pharmacies that you can drop into to access that, or people can call 119 as well in order to get the support that they need. So hopefully all of that kind of gives a little bit of an overview in terms of the vaccination programme, how that maps into the actions that we're taking across system partners, but really, really happy to take any questions that people have got.
Thank you all. Just before I hand over to, I know we've got some members that want to ask questions. Can I just ask, I just want to make sure that places like Hamo's House, the Shekinah, are working people, they get an opportunity to have these vaccinations. So obviously Hamill's drug and alcohol rehabilitation, and you've got Shekinah who the homeless come into. So are we making sure that those people, members of the public, are given the opportunity to have vaccination?
So certainly if they're supporting vulnerable groups, then they will be in line with the eligibility criteria, but the specific services, Councillor Murphy, I can go back and double check and make sure that that's been picked up.
Angela.
I was looking at this slide on the Winter Surge Commission capacity for discharge, and you spoke to that very comprehensively, but there seemed to be a massive amount in there. And my questions around, I think you said, that particularly this second list of bullets, these new initiatives, I think you said there was an additional capacity. But my question was, are these things sort of newish tasks that existing personnel have got to take on, or are you bringing in new people? And then going to your final bullet, which is, one would almost think should be the first bullet, you know, how are you managing all this working together? Because obviously it's essential, and it's essential to the ongoing way you wish to work. So it was sort of how, at the moment, how successful is this integrated working? Do you have to have new capacity, or are people picking up all these additional tasks?
Absolutely. So I'll do my best to answer that for you then. So from a additional capacity perspective then, so some of what I'm describing is about how do we ensure that we have the right care capacity on the ground, so in terms of that direct contact with patients, in terms of as we've moved away from putting as many people, discharging as many people into bedded settings, as we've put more people out back into their own homes, it's about making sure that the direct care on the ground for those patients is available. So in order to support that and prevent any destabilisation of the local market, our approach has been in terms of looking for that additional capacity to come outside of the city. And there's a really good argument for the reason we've done that, as we don't want to destabilise the local workforce and recruitment drive, as that's a more long-term piece of work. So that in terms of that capacity that's coming to Plymouth, specifically through working with Plymouth City Council's Independence at Home service, we've bolstered the amount of care workers to deliver that direct care. So it hasn't had an impact in terms of, we don't need more, it doesn't necessarily need more sort of managerial or administration from that perspective, but it delivers more care for the people that those are vulnerable communities in Plymouth. And in terms of the integrated working bit, so that's absolutely key. So certainly health couldn't do their jobs without the local authority, and likewise, and it works the same from a Live Well and UHP perspective as well as our dom care home providers. So through some of the forums I've described in terms of specifically if I pick out the daily call, so we have a daily 10:30 call which has local authority commissioning, chaired by ourselves from the ICB, some of Michael's team from the integrated hospital discharge team attend. We've also got Live Well there, brokerage as well, Cornwall as well, so reaching across into Cornwall and Devon as well. So we come together on a daily basis, understand what the needs of our patients are, where there are escalations or blockages, we come up with a plan together to understand how we can get those people discharged as safely as possible, and then that feeds back into some of our governance processes around how we commission the right capacity, how we make sure we're spending our taxpayers' money in the most appropriate way to support our patients, and through that integrated working that we've really developed on over the past few years, helps us drive forward our future plans and delivery around strategy. So I would reflect on that and say it works really well.
Thanks very much. That really sounds good. So you're really saying people appreciate why they're having to do these extra things, and it's working out on the whole. Great.
Yeah, of course.
I mean, it's a really, really good question, and one that's really important for systems, because when you plan for winter surges these days, they are very significant challenges for systems. So you need to take multiple sets of actions. So enhancing your capacity, doing your work around prevention of admissions. I heard Michael, talking about supporting people in care homes so they don't need to go into hospitals. And I think the only thing I wanted to add to the work that Ed's describing is flow through that capacity is also really important. So yes, you need more, but you also need people to move through that well and be well supported, because that actually is another way you really use your capacity to its best ability. So I think, yes, you have, so it's a combination of all those things that help systems, because that's what it is really. It's everyone's response to what we know is the increased demand, which starts with the numbers that UHP model so well, actually, in terms of where we predict what's going to happen, and then we need to use all of those bits to come together. And when one of them doesn't, that's when you get a problem. So it's a combination of all those factors that will help deliver the winter.
Ray?
Thank you. Good afternoon. I'm wondering about vaccinations and how successful the uptake is among staff at Derford Hospital, given that previously, in my experience, not a lot of people like taking up the offer. How long are we asking staff to stay off once they've contracted flu or COVID now?
I'll come in on that. So from the guidelines, particularly with IP and C for keeping staff off, it's normally we'll ask them to self-certify for the week, just for all intents and purposes, which the majority of staff would do. The official guidance, however, I don't have to hand, but I will see if I can get hold of that whilst I'm sitting here to feed back to you. From an uptake of the vaccination, it's certainly had an earlier, higher uptake, and my colleague Rachel, that's exec director in the room, can testify to that as well and support. But the higher uptake earlier on compared to normal, what we are seeing is the difference with COVID vaccinations. We normally offered those both at the same time, and we saw a less of an uptake, whereas this year decoupling them and offering only the flu has seen a more positive impact and uptake at this moment in time. And not to put Rachel on the spot, sorry Rachel.
Michael's absolutely right. We have seen an improved rate than where we've been in previous years, but we do hold the mirror up. It's still not good enough. I mean, we want to be aiming to the 50s and 60s. What the message we're trying to give is that, in line with the comms that Chris mentioned, is the importance of the early protection, particularly, what we don't want is people waiting. You've got to match the message. You don't want people waiting for when they think the peak's going to be. We need that protection all the way up. So we've had different approaches that we've had feedback from staff from last year that we're mobilising, but it is a everyday campaign out there with wards going to the people. Actually, we recognise people are working hard enough, so how do we bring this to those individuals? What we think is making an impact this year is that we haven't offered COVID and flu at the same time because there was some nervousness about the COVID vaccination. So we'll do our usual debrief at the end of the season, but continue in this public forum to say to people, please protect for yourselves, your loved ones and those that you're caring for. Thanks, Michael.
Okay. Andy.
Thank you. 2 questions, if I may. The first one, this is an excellent plan, by the way. I read it with interest. It's called the Winter Plan. Do we have a disaster plan? If we were ever to see the likes of COVID and a pandemic of that nature again, do we have a disaster plan in place? That's question number 1. The second question is regarding the ambulance handover thorny ode issue that we've had for a number of years. I don't understand the data here. The aspiration is 30-minute handover, and looking at the chart on the second page where it says it's over 45 minutes, the concern I have is many of my residents have contacted me and told me horror stories of an hour, 2 hours, 2.5 hours. Can we have some understanding of what is the actual handover time? I can see the aspiration. Is it actually on average 45 minutes? And what further work's been done in this respect? Thank you, Chair.
Thank you, Councillor Lucker. So I'll hand over to Michael in a minute to answer the ambulance handover question, but in relation to further emergency preparedness and how we approach that, absolutely all partners have disaster plans if we get to that stage, but we operate a national Opal rating scoring system that we work through, and equally there's a critical incident type approach as model as well, and we work collectively across the whole of the Devon system. So we've got a command centre within the ICB that supports the hospitals, monitors the metrics, and reacts and brings people together if we do find ourselves in a position of enhanced escalation, that we can come together collectively across the whole of Devon and support each other in order to depressure the system. We do a lot of practice as well. So as part of our preparedness for this winter, we've been doing modelled scenarios around actually if we saw a sudden surge of people with COVID or other illnesses, actually the kinds of actions that we would undertake in order to respond to that. So that's all part of the process that we go through on a regular basis. But I'll let Michael pick up the ambulance.
Yeah, certainly. And I apologise for the confusion within the ambulance metrics. It's been a moving feast as we've been going through. As you all know, Councillor, our ambulance offloads has been significant and have been a huge challenge for us over a number of years, as we've seen those impacts and holding ambulances for several hours prior to. However, we've made significant inroads in our performance. The national standard for any ambulance offload is 15 minutes. At the moment, due to the sustained pressures across not only Plymouth but also the UK, there is a mandatory offload target within 45 minutes. So if we're unable to offload that ambulance safely, or the patient rather, within 30 minutes, then the patient will be brought in to the department and offloaded onto a trolley and left with our care, which we're able to respond to. Thankfully, at the moment, although you've accounted for some of the delays that your constituents have seen, we are making huge progresses into that. Currently, our average handover is 16 minutes, Councillor, with just under about 950 hours lost for this month. And we will continue to remain committed, to achieving the 15-minute standard. At the time of the plan being written, it was a different story, and we were trying to achieve our aspirational target as well as our operating plan, and balancing the risk between the systems of how we move patients through the system and without putting them at further risk, understanding that the community is a priority and any patients waiting for an ambulance is key for us, and that was a real driver and a focus across the hospital site to ensure that we are looking after those patients that have no access to care or are waiting, as 15 minutes or 30 minutes is a long time for people in crisis.
I did ask this question before and sought an assurance from you regarding the level of care that takes place whilst the patients are in limbo. Can you still give me this assurance that at every stage, whether it's in the ambulance, on a gurney outside when they've been offloaded, as you alluded to, or in transit to the ED department, there's going to be constant medical care?
Always, full-heartedly can confirm that they will always be looked after with consistency and continuity of care, and to provide assurance to the board and the public that we all have those plans in place to ensure that we have oversight of all of our patients, and we are maintaining a commitment to ensure that they are not being held at all for any in-state or circumstance at this moment in time. So thank you.
Will?
In previous plans, I'm sure we've been presented here about the virtual wards and then being like a proactive, like the vaccination's a proactive thing. It's a proactive thing. I suppose it helps with discharge. How successful? Because I have seen papers with quite high numbers of beds on virtual wards, and then this year it's got 37 of 60. Does that mean there's only 60 virtual ward beds? And last year's paper said 125. So what challenges have been for virtual wards? And is there much scope? How limited is that limiting the scope for sort of proactive help this.
Yeah, absolutely. So do you want me to start, Rachel, or do you want to come in, Rachel? Sorry, I couldn't see if you were.
A bit closer to this one. So you're quite right. So we have two forms of virtual wards that are operating for the residents of Plymouth and Devon. We have 75 for those that have acute pathways of care, so respiratory, cardiology. At the moment, we've got 75 beds open. Sometimes they fluctuate, depend on staffing and sickness, but largely 75 beds. But our occupancy has dropped. So typically, we've been at about 50 of those beds being full at the moment, but there's a huge turnaround work happening across our teams, particularly in the run up to Christmas, around awareness of the pathways, making it easier to onboard. So actually it becomes a phone call and we make that much easier. We've also, working in partnership with Live Well South West, we have had an aspiration to open 125 frailty beds. Those would be available for our primary care practitioners to refer to, as well as our front door of the hospital, and also if people had a period of stay in the hospital, post that for a few days of further medical support. Unfortunately, because of some delays with recruitment, with some of the competency skill assessment work that we need to do, we had to slightly reduce those bed bases over the summer into now. So currently we have 68 beds of those that are fully open, and we will get back up to 95 bed capacity just before winter. And we are on a quality improvement series of weeks with Live Well and internally with the Trust to make sure that we get up to the 80% occupancy counsellor. But it has been in a period of turnaround. We're learning from that together. We're taking a quality improvement approach and we're getting really good feedback. And I think we I've quite got the numbers, I haven't looked at my emails today to see what the occupancy is, but we've certainly seen improvements over the last couple of weeks, which is good news.
I've got no more questions from members, but
It was just further to say as well, just to come in with Rachel, that the virtual ward is still quite a new feast for the NHS as a whole. But some of the fantastic work that's been undertaken, both with the Live Well and the hospital, is seen leaps and bounds. And already within the numbers that Rachel's alluding to, we're onboarding nearly 6 to 7 patients a day onto our community frailty virtual ward, and really stressing our acute virtual ward as well to its maximum capacity, and getting some fantastic feedback from our constituents around the use of it at the minute as well.
Do you want to add anything, Will, or are you happy? Yep.
So obviously it's good that from the previous, over a period of time, it's good to see things like the ambulance handover times have got less, even with the increased demand. But one area that sort of does worry people is the use of temporary escalation beds. So there's the kind of spaces on wards where sometimes a patient might be before they're actually put into a bay, or in between one process and the next. Obviously, I don't know if that's how recorded is that, but we wouldn't want to push people from the ambulance and then actually have that on a busy ward where there's all the risks associated with that. So, is there a target for eliminating that kind of? Might be necessary sometimes, but eliminating that.
Yeah. Yes, absolutely. So as a trust, we do not tolerate corridor care as we know it, or as the public would determine. Temporary escalation spaces, so we're waiting for the true definition from NHSE. However, for this moment in time, we as a trust are taking it as a standpoint that it is a space with no bed head, so no oxygen, no suction behind the patient, effectively, as we would say. That is what we're classing as a temporary escalation space. We recognise that we have had to use that for a period of terrible demand that we've seen, where the ambulance offloads has pushed the patients to balance the risk across both community and the system, and we've responded to that effectively and completely de-escalated the site. So although we've seen a temporary use of temporary escalation spaces, pardon for the use of the words, we have taken measures to respond to that effectively, so we're no longer tolerating corridor care, and again, colleagues within the room are all joining us in ensuring that we're getting our patients out effectively and efficiently to respond to any surges in demand to prevent them from happening in the future.
You okay? Is that okay? I've got no more questions from members. Just a quick one. As we were talking about care homes earlier, I can see that you offer your vaccination programme to the care homes, and there's 10,000 eligible for that. Can you just give me a ball figure of how many's actually taken up the vaccination programme?
So I don't have that to hand, except to say that the uptake's been better this year across the whole of Devon, and those 10,000 are across Devon. But I can get the number and share it with you. There is a data pack that comes out every week that shows the uptake numbers across all groups, and that's shared with the public health team in Plymouth as well, so that we can understand exactly where the uptake looks like and if there are particular areas we need to focus. But happy to get that number and share that.
Brilliant. Thank you very much.
Yeah, I was just going to ask about the uptake as well from Pauline Chair's question. I was going to say, is there any boundaries or people's resistance to the flu jab, you know, cultural beliefs, age, pregnancy, things like that?
It's all part of the learning that goes in each year. So there's a process that we go through to understand where there may not have been the level of uptake and why that might be. And a lot of the learning through COVID and the COVID vaccination programme as well around some of the different approaches in different communities that can help. So that's really developed over a number of years, and is something that we continue to kind of monitor to understand and then target our approach.
Yeah, I was just thinking it'd be good to record the reasons, and then it would be something to work on in education, wouldn't it?
That's it. We haven't got any more questions on the winter plan. Thank you all very, very much. I can see you've been working really, really hard on it, so thank you. We're going to go on to item 8 now, which is readmissions, and we've got Rachel Connor, and we've also got Angela online.
Yes, I'm here.
Thank you.
Thank you, Chair. Are we able to load up the slides? Elliot,
Would that be okay? Yes, I think I'll struggle to do it on my end.
So I think I've met colleagues before, so members, thank you very much for the invitation today. And, Angela, do you want to introduce yourself?
Yes, so good afternoon, colleagues. I'm Angela Mater. I'm the Chief Medical Officer for Darrowford Hospital. I started here in June this year, just coming over from Wales. I'm a GP by background, and I'm here to talk to you a bit on our readmission data, which I think was the ask. And so just going to run through some slides, if that's okay, and then I'm happy to take any questions at the end. So I don't know if you can see the slides.
Just loading up now, Angela.
Let me know when you're ready and then I'll start.
Sorry, I've got no Wi-Fi to...
I can see something has come up on my end, but I don't know if you've got all... Oh, it's gone.
Do you want to perhaps start, Angela, just explaining the definition of readmissions, and then we can get straight in?
I think it's come up. It's there. Okay, so if I take the next slide, please. So just to start, really, you know, the definition given by NHS England and what readmission is quite broad. So the readmission is defined when a patient is readmitted to a hospital as an emergency within 30 days of their previous hospital stay. Quite important to note that it doesn't include it doesn't include any clinical connection or a link to the previous condition the patient was admitted for. So clearly there is, when we are counting our readmission, there will be a number of patients who are coming back and reattending back into Darriford Hospital who have got a new condition or a new complaint and with no sort of worsening of their initial presentation, but presenting now with an unrelated matter. And I think that's really quite important, because therefore we need to really look at readmissions with multiple lenses and look at the sort of key factors why patients are reattending. The first one is really from a clinical perspective, is that condition related to the previous and the index admission, or is it a completely new factor, which is we need to take that into account. So the other really part we need to look at, was it anything to do with the discharge of the index and admission? So was there a coordination issue of care, going back into the community, or did we have a poor communication when we discharged the patient and the patient wasn't clear about where to escalate to and where they're getting the support for by returning back into the community? Of course, there are always going to be operational pressures which are going to be part of our really business as usual, particularly now going into the winter months, and that sometimes can drop the quality of how we are discharging. And so it's really important that we mitigate that and we have the right safety nets in place so that we are not putting patients at risk when discharging them back into the community without with those safety features in place. And of course, there are going to be some patient-specific and individual factors why people are attending, and these could be, for example, social breakdown of their care. So we know that patients are very reliant as much as on clinical care on social care, and if there, for example, are some environmental factors or some social breakdown, people do often reattend as well. And again, that is down to not necessarily knowing where to go else. And then we also know that there is a significant issue around our data quality and how we are coding our current readmissions. And I'll come back to that a bit later in the presentation, because I think that is quite a significant factor when you look at our figures. If I take the next slide, please. So really, I want to spend a couple of minutes on talking about readmissions, because readmissions is of course not the right thing to be, and particularly if it was down to a poor discharge process, it's upsetting for the patient. It is a real inconvenience to reattend back into the hospital, particularly if it is in a distressful situation for patients and families. But there is also the other side of staying too long in hospital. And I just want to really draw down on some of these risks, because they're quite evidenced and quite well known now that particularly certain groups of patients really struggle and come to harm with a increased length of stay. So that distress I was talking about coming back as a readmission also exists when you're staying longer in hospital and actually want to be home with around your loved ones. We also know that the average length of stay, for example, for frail, complex patients is up to 21 days, which is quite a significant amount of time for patients to be away from their home and from their usual surroundings. And it is also known that patients will have more likely, and particularly frail elderly patients, will be very susceptible will be more likely to have hospital-associated disabilities. And they are really quite significant when you think about numbers. So 30% of older people have a higher chance of developing hospital-acquired disabilities. And these aren't of any sort of small degree, because some of them are quite debilitating and can have long-term consequences. So, for example, 2 to 5% of muscle loss is lost every day when you are immobile, and that over 10 days or 21 days is really a significant amount of deconditioning patients are experiencing. And it's again, there are lots of initiatives in place to mitigate that by mobilizing patients. But again, in busy environments like hospital, that cannot or very often cannot be followed through as well as it would be in other environments, particularly if patients are at home. There is a higher risk of falls, and we know older people have a 50% higher chance of falling than younger people. Higher chance of developing deliriums. Again, that can be increased by 20 to 30%. 20% were frail elderly patients, and also functional decline I talked about. Mental health suffers quite significantly in hospital, up to 60% develop depressive symptoms, and of course healthcare associated infection and pressure injuries are part of those hospital associated disabilities. So quite significant consequences being too long in hospital. Next slide, please. Let's talk a little bit about data. So this is the data which we've seen and we've been following. And on the top left slide, you can see the total number of readmissions is significantly increasing. And that really worried us when we saw this. And we then undertaken quite a number of deep dives to immediately seek some assurance, but also look at the areas we need to improve. We also know, if you look at the top right slide, that our overall total admissions, or total discharges has gone up as well. So proportionately, the readmissions haven't actually gone up. So our current rate is about 7.2%. The average nationally is higher. There is something around data quality, how things are being measured, but generally we are quite assured about the fact that our discharge numbers have gone up and our percentage of readmissions hasn't actually increased significantly, which is reassuring. The second reassuring bit is the top right graph there, where you can see that the complex discharges, which are those patients who have got a number of care needs, so that can be social, clinical, and particularly around psychosocial as well and environmental needs when they come back into the community, those readmissions haven't actually increased and are staying within normal parameters, which is quite reassuring that those particular complex patients, we are getting it right and the discharge is a successful process. If I take the next slide. So we've done a little bit of sort of, as I mentioned, a deep dive and really trying to tease out the sort of areas we know we are contributing to our increase in readmissions. And one of that is, of course, patient complexity. We know patients are getting older. We know they're living with a number of increased complex long-term conditions, and therefore are going to be more vulnerable when we are discharging them back into the community. So this is something we need to adjust to, and we also need to be be mindful of when we are discharging patients. There is certainly something around communication and planning. So discharge planning really starts at the time of admissions, and it is a co-designed process with families and patients. So do we talk regularly and consistently with patients about the discharge process so that it doesn't land as a surprise when it actually happens? So it's really important that we're having this ongoing communication and planning throughout that patient journey in hospital. And we can get better at it. And there is certainly a variation on the weekdays and the weekends when staffing levels vary. And then the third bit I mentioned around coding and, are we coding an apple like an apple? And, is a readmission really a readmission or is it actually a planned follow-up? And I'll come to that in a minute. If I take the next slide, please. So this is the bit around data. So I'll get that probably out of the way first. So we've looked into some of our data. So looking at 100 readmissions and compared them to the definition and identified that actually only 43 of them were true unplanned readmissions. So they are not admissions where it was a planned follow-up. So I'll give you an example. In our surgical admission unit, where we have a lot of patients coming in on day one, are identified or are diagnosed with a surgical condition, and a procedure is then lined up the next day. But we are very often coding them as readmissions, but actually this was a planned follow-up and we should be coding it differently. And there are numerous other examples, particularly in the same day emergency care setting, when we are bringing regularly patients back to the next day for another blood test or for a review. And clearly these aren't readmissions, these are planned follow-ups. So again, very important that the data quality is right. If I take the next slide, please. Important for us, and at the core of everything we do is, of course, patient safety, and we needed some assurance around the fact that we are not causing harm to patients because they are coming back for readmissions. And this is quite important when we look, and the way we look at it is really through our incident reporting. And we have seen a reduction in harm incidents related to discharge and readmissions, which is reassuring. We also seen an overall reduction of incidents where readmission was a cause of concern. and that again is reassuring. And the third element, which gives us again some peace of mind, is that our ED delay related harm, so patients who stay a long time in ED, we know are more susceptible for harm, that has also reduced, and that is clearly because we are getting better at patient flow, which is a positive thing as well. So patient safety, we really needed to look at quite urgently, and we are quite assured from the data we've seen that that is less of a concern than it used to be, and also, but that doesn't mean that we don't keep our eyes on it. If I take the next slide, please. This is the bit which is, which is close to my heart, and really what matters to us, particularly clinicians, when we look at what patients actually feeling and how they're experiencing going through our care services. And when we did a survey on our patients, over 50% of them, or just over half of them, said that they were not clear on their discharge plan. They didn't know what happens next, and they didn't think they were well supported when they were going back into the community. So the main concern was around inconsistency around communication. So people were saying different things, and the coordination of the discharge process was poor at times. And that is really what matters, and we really need to do something about that. And whilst that wasn't causing any patient safety concerns, it's still not right, because patients aren't happy with the process, and are certainly struggling with coming back out into the community without that information. So really important that we do some more work on how we are improving our discharge processes. Next slide, please. So therefore, our next steps, and where we want to go, particularly in our endeavours to improve our position, is doing another audit around patient voice, and that is going to be talking to patients who are come back with a readmission, and we want to find out why they reattended, and what were the key reasons why they felt they needed to come back. Was it a clinical worsening of their condition, or was it because they didn't know where else to go in the community, or maybe didn't have access to the right places where they needed to go. We definitely want to work on our data quality, so making sure that we are correctly coding our readmissions, and that will give us a clearer and a consistent narrative around our readmissions. We are absolutely working on our discharge processes, and there's a whole piece of work happening around quality improvement, where we're looking at breaking down the discharge process. What are the key components of it? When do we need to do it? What are the timelines of it? When do we need to start talking to patients about discharge? And are we all saying the same thing? And are we clear around and are we seeking that understanding from the patient as well? So how do we ensure ourselves that the patient really is clear about what the messages were and where they need to reattend if things don't go right? So something around the process improvement is absolutely a core in what we're currently doing. And then I just want to talk a bit about just the last couple of seconds around system review. So, we do, of course, need to work with our partners. The patient, and I'm a strong believer of that being a GP, is that we must connect the pathway from the community into the hospital, and equally from the hospital back into the community, because we're talking about the same patients, and therefore pathways are going to be absolutely key moving forward. So frailty pathways need to be very clear in what is delivered in the community, and is that right sized? Does it meet all the needs of frail elderly patients, and are we utilising it correctly as the first point of contact? As we know, patients very much want to be cared for in the community, in their own environment, and very often, as I mentioned at the beginning of my presentation, it's the right thing for them, and the right environment for them to be. And we mentioned earlier around the Community Frailty Virtual Ward, which is a service which is particularly dear to my heart, because I've done similar work in Swansea, and really pleased to see that I was able to advertise this here in Plymouth as well. And it is a service which is around an MDT. So in essence, you're having a ward from a hospital ward, you're delivering it in the community. The same professionals, you've got pharmacists and nurses and doctors and therapists who are delivering care for the elderly, wrapping around their needs. And this is not only around the clinic clinical needs, but the wider psychosocial needs and connecting them to the third sector as well. So whilst it is called a virtual ward, it isn't really virtual because it is a very much a face-to-face service with very competent clinicians who are addressing the needs of frail elderly patients. And why is this service so important in the context of readmission? Well, it avoids readmissions, because if you're landing patients safely in services like this, we will see automatically less readmissions, because people's confidence coming into hospitals certainly reduced when they come back into the community, and by wrapping around care when they come out, we can build that confidence back up. So that's probably all I want to say from my end. I'm happy to take any questions, and that's the end. We can probably stop sharing.
Thank you, Angela. Has members got any questions? Ray?
Thanks for your talk. It's very interesting. As a porter working at Derford Hospital, we often find that the line of communication between expert medical staff and patients often breaks up. They don't know what's going on, and by the time we get to transport them to where we're told to transport them to, they've got a completely different idea about what's supposed to be happening, and the news hasn't filtered back to them at all. So they're quite distressed at this point. We're moving and they don't know why, and they expect us to know everything that's in their care and treatment plan. And of course we don't, we're just porters.
Thank you. And to your last statement, you're not just porters, you're a very valued member of the staff, I think, and I just want to point that out. And but you're absolutely right. I think, you know, the level of communication to the patient is absolutely key, and we got to get better at it. And at the point of discharge, it's particularly daunting, because you're leaving an environment you've been for 3 weeks and going back into an environment where you haven't been. And as I mentioned, around confidence with frail elderly patients, it's quite significant. And if you don't do this right, and we don't make sure that the safety nets are in place, we are putting people at risk, and that is not the right thing to do. So communicating and discharge planning is absolutely key. But also, you know, it's an ongoing process, as you said. It's, you know, every single day we need to make sure that, you know, everybody's clear about what's happening to them, because it's a frightening and familiar environment. And I talked earlier about delirium, and, you know, patients with cognitive impairment particularly are very vulnerable, and therefore it's even more so that we put them at ease.
I'd also say the other quality work that's happening across the organisation, our Building Brilliance programme across our wards, and the implementation on our audit of kind of 3 questions every day. Do you know what's happening today? Do you know when you're going home? Do you know what to expect next? So that whole culture, it's a cultural movement, because you're absolutely right. You're there, you've got to communicate other plans as a network to do. So it may be that we come back and speak at a later date about that Building Brilliance programme, which is a real heartbeat of the organisation, so that we get those, it's the basics right, that people know what's happening today when they're going home, and that we can transition them through that.
Thank you.
Okay. Has anybody else got any more questions? It was really interesting to be honest, and I was quite interested in the patient experience, because obviously you can see there that really does need to be worked on, and obviously in your next steps that's what you're going to be doing. So I think for us as a scrutiny committee, I think we'd welcome you to come back at a later date to give us an update of how this is panning out, because I think you're absolutely right. It is really important that a patient understands what is happening with them. The reason that this was brought today is because people had come to me, and it, unfortunately was care homes again, where patients had gone into a care home again, and then they were having to be readmitted back into hospital because they'd been discharged from the hospital too early. So that was the reason why this was brought today. So it will be really good if you could come back at a later date to see how much that's improved with this programme that you're doing.
Yeah, happy to. And I think, you know, just around care homes, I think it's obviously a slightly different setup, isn't it? Because we need to ensure that communication directly to the care home as well, not just with the patient and the family, because, you know, very often nursing home, we've got qualified nurses working in there. So, you know, that clinical care and that clinical handover needs to be robust. So if you're mentioning that patients or care homes were not content with that, I think it'd be good to know which care homes they are, so that we can make sure that we are getting better at it, and you know, ensuring that those communication channels are very clear, because you know that I would think is slightly different than discharging people home. It's just a different pathway.
Okay, thank you very much, Angela. Anybody else?
Thank you.
No, thank you, Rachel. Really appreciate you coming today. Thank you. Thank you, Chris. Really
Thank you.
Really appreciate you all coming today. It's been brilliant. Thank you. So,
Thank you. Bye bye.
Take care.
Bye. Bye.
Bye bye.
yeah, and Michael, thank you.
Bye.
Item 9, action log.
Thank you, Chair. 5 actions on your action log, 3 of them complete, 2 of them in progress. I'll come back to the select committee item and our next item, work programming, if that's okay. The first one, 94 on your log, I've chased for a response and I'll circulate that around to members by email when it comes in. Happy to take any other questions. Thank you, Chair.
Members got any questions? Angela?
Thank you, Chair. Just very briefly, I don't know if we're going to come on at the end to talk about the ideas for discussion, but yeah.
For future,
Yes.
Yes, we will. Yeah.
Because I think this might link. If we looked at, shall I wait? If you look at the action complete added to work programme for consideration at the appropriate time. This the update on the NHS reforms and restructure. Sorry, in the green, it's the.
Yeah.
You see, I'm wondering if it's appropriate to add to that how the committee almost restructures its own way of scrutinising the new way of working. But I could leave it to the discussion at the end.
Okay. Yeah. Okay. Thank you. Any other members got any? No? Okay.
Thank you, Chair. We're on work programme? Yes, lovely. So members will note that in the work programme, our next meeting is scheduled for the 2nd of December. That's because we've moved this meeting back to today, so there's now not a lot of time between them. My suggestion is that we move that 2nd of December back to the 14th of January, which is another Tuesday in January, but I'll circulate a variety of dates by email, and through you, Chair, we'll try and pick the most convenient date. That will unfortunately mean that the meeting after that is also quite close. So I would propose that goes back to the 4th of March, just so that we have about a month in between each meeting. But we'll try and arrange that so it's at least inconvenient to members. In terms of our next meeting agenda, it should be noted 25th of November, there's a site visit to the Dartmoor building at Derriford, and all members should have the invite. If you don't, please let me know. And then
Rachel just wanted to say she needs to give her apologies for that meeting. She's now been summoned to another meeting that she has to go to, but she has got the team ready for that visit. All right. And she's sorry she can't join you.
Exactly.
Brilliant, thank you. So in terms of the 2nd of December, 14th of January move, we've currently got PCC CQC outcomes report, which I believe is ready, Gary, to come to us.
Did you say that January?
January.
ready at last.
Okay, thank
In
you.
a long time.
We've also provisionally got an update on the Armed Forces GP surgery or dental update, an item we looked at a while ago and added to the work programme to bring back. So I can reach out on that. And there's an item potentially on unpaid carers, which Gary could elaborate on if he needs to.
Yeah, it was an item that we offered up for today, but actually I've felt, and I would also say through our CQC inspection on site, we talked a little bit about scrutiny in some of the areas that could be involved, and it was one of the areas that we had talked about. But I think there's been some great work going on with our carer strategy and the themes and all the things we do. This is around unpaid carers, so all those people in our city. So I thought we felt it was really good to bring it to scrutiny, just to have that opportunity for you guys want to see it, but to also challenge and talk that through. So, and it was something that was already ready for us as well. So it felt like a nice time to bring it.
Yeah. On that CQC report, I'm sure we're probably going to have lots of questions on that, I'm assuming.
So I think in terms of how I would suggest we would present that, we will bring forward what it says in terms of its outcome, but we'll also talk to you more about some of the themes, so some of the good bits and some of the areas that we need to tighten our belts on, because every inspection report covers all those things. So that would be how I would tend to bring that one. Okay. Yeah.
The only reason I'm asking that, Gary, is because we've got three items there. What I don't want to do is bring in members for a meeting that's only going to last an hour or so. If I didn't know whether we had room to put something else onto the agenda. The only reason we want to make sure that, because some members have got to take time off work, and what I don't want is for them to take time off work and then find that they're only going to be an hour or an hour and a half. And we need to make sure that when we do our agendas, it's well packed for everybody. I know we've gone over a little bit today, but I'd rather it go over a little bit than be here and then we've gone too quickly, if that makes sense. Yeah.
Yeah, thank you, Chair. Through you, we'd have the standing reports again, so performance, finance, which, as we've experienced today, take up a fair bit of time. I'd work out timings with you ahead of the day, but if members have any other suggestions to add to that meeting, even if it's not now, please send them in, and I'll bring them up with Chair at the agenda, sir.
Yeah. I mean, I remember last time when they brought in the Armed Forces GP surgery dental update. Basically, it wasn't an update. It was just 2 bits of paper telling us what they should be doing, what the covenant says they should be doing. That's not what we asked for. So I'm hoping that when they bring this in this time, it's actually what they're actually doing, not what they're meant to be doing. If that makes sense. Yeah.
Could I ask a question, Chair?
Yeah.
If we did fit something in, would it be plausible to fit in an update on the urgent treatment centre? We'd have 3 months data by then, wouldn't we? Because we'd be right in the middle of the winter pressure time, and it'd be nice to know how the figures are at the UTC. It might not work, you know.
I think what we can do is, because we'll have an agenda pre-setting anyway, so we can discuss it once we know what we're going to be getting in. Elliot, is that all right?
Yeah, noted. Thank you, Chair.
Cheers. Angela, what? So now we're on that bit. do you want to?
Thank you, Chair. Well, sorry, I may be just jumping in, but looking at this slide that we received on the 29th of October, when we'd had the masterclass, and at the end of the masterclass, there was a tiny discussion about how we could work together in the new circumstances. And we said, let's put that to this meeting. So here we've got some really useful ideas, and I think they're all good. You know, I think it should be a mixture, a menu of these different things. But the thing that was really worrying me when I looked at these for this discussion, I looked back at some of that masterclass and some of the slides that we had. And it was very interesting and terribly intense. But when I got to the end of it, and essentially they're talking about the principles to completely change the way of working. So it's at the neighbourhood, and there's all this talk of the neighbourhood. I just think we need more thinking or more help. I need more help on how you scrutinise, the transition to that form of that system, and then how are you monitoring that system? How do we know how that system's supposed to work? So, I mean, I'm not sure that anybody knows this now. Maybe they do. But I just thought, you know, maybe it's a workshop, maybe it's an informal discussion so that the people who are involved in this transition tell us how they're doing it, how it's going to end up, and how we can scrutinise it. Because, as I say, it won't be like, I imagine it won't be like, what it could be, you know, our first session today when you've got all the figures and we look at the spreadsheets and we say, well, why is it 500 and not 460? I mean, it won't be like that, will it? You know, I doubt, well, will it?
So I remember some of the conversations around the masterclass, and I think what we've got is an NHS 10-year plan which needs to deliver.
Yes, it's 5 years. Yes, right.
Massive change towards neighbourhoods. I suspect, and at the moment, I would say I don't think there's a lot to bring. There's lots of clouds and ideas and thoughts about how we implement that, and the ICBs are getting themselves set up structurally differently, and people are starting to translate what that might look like for us. So for me, with my boss and the boss of the hospitals and others, we've got a session before Christmas to go, what is this, you know, what do we really want out of that, and how's that programme going to drive forward? So I suspect, Angela, it's not something that we'll do once. I think what probably from a scrutiny point of view, as the plan develops, is going to be to bring it in here and to scrutinise that plan. And I think out of that, you'll see the programmes of work, because it is quite, you're right, it is quite huge, it is quite game-changing in as much as, you know, moving things out of an acute trust into communities. There's some things that should be out of an acute trust anyway, they don't need to be there. But how that all comes together and its relationships. And then as each part of the plan comes, I think there'll be bits that you can then ask those questions about. It's too big a... And no, but if you asked people in Plymouth now, senior people, their version, you would get different answers, because we're still in the kind of forming stage of that, if that makes sense.
What we could do is when it starts to come into scrutiny, we could like dissect it, and if need be, we could do like task and finish group or like a workshop or something on it at that point, rather than trying to do something now. Once it starts to come in, Angela, we could look at it and think, actually, let's do a task and finish on that, or a workshop or something. I think that's probably the way forward, if that's all right with you. Yeah. Okie dokie. And Will, you wanted to just give a little bit of a A or B for us on Marie Curie or something.
Just going back to what we've just, I think it was quite good last year. They brought their winter plan back through and like reviewed it in, because for sort of it's about understanding the whole system, isn't it? We're not looking at the hospital or the doctor's surgery on its own. We're looking at how this all interacts, and there's quite a bit there, isn't there? That was quite good, because I mean, give them a due. I think it's better than the first years I've been on the committee. The performance seems to be. I know they're my employer, but you know, I think you can see some improvement there. Obviously, it always needs to be. I don't know, maybe I think wellbeing hubs were on our list of things. If we were looking for something for the January committee, was that on it? I'm sure, was that on one of our, or am I on the wrong? the wellbeing hub? But I mean, that's perhaps something we're doing in the community already, which would go with part of, obviously, you're saying this 10-year plan, and it's much, some of these things are still, you know, at the strategic level, we're not near being implemented, but that's something we are doing, which is within that. I mean, obviously, time the plans will come through, it might be superseded by something else, but that might be, because there's quite a bit going on there, and I think there's some things have been successful and some things haven't been so successful, so looking at those, maybe.
Well, I'm quite happy to add it to the
I don't know whether
work
that might be a good
schedule.
thing for that, you know,
Yeah,
that particular, because
if at any point, if members want something added, or there was something that they're really particularly interested in coming to this scrutiny, please just let us know, because it's not about just us what we want on it. It's about all of us working together. And if there is anything that you want put on the work programme at some point, then please just say. And if we can get it on there, we will. Yes, go on.
I mean, I think that's a reasonable idea, but just also linking, Angela, to your point, the wellbeing hubs, our family hubs, and all of those things are actually a really important, will become a component of helping deliver the neighbourhoods plan, actually, because those are places in our communities that will be saying, what else can we build into those that helps bring that care closer to people's houses? Some of them already have. I was at one, you know, it's got maternity things happening there. They've got, you know, all the maternity nurses and others running services out of them. So that might be quite helpful, because I think it will build a bit of that knowledge into future stuff with neighbourhoods as well.
Thank you all. Well, you wanted to say about the Marie Curie?
I know quite a few of us, you know, we're quite a bit of on the end of life care subject over the past couple of years, and we learnt about Marie Curie and the work they were doing, you know, both working at Derriford to help people, you know, on pathways from Derriford, and also proactively in the community. They had the Estover project, so looking at people doing the advanced care planning and looking at their care needs, so people weren't, you know, on those kind of emergency trips in an ambulance. They were seeking, you know, some help before they got to that stage. So Marie Curie have organised a Lights to Remember event, so very much, you know, for family of bereaved, and it's at the end of the month. It's on the, Sunday the 30th, and over at the Crown Plazas where they're hosting it, and we've asked for Smeaton's Tower to be lit up yellow. So just hope, you know, invite. I'll try and email people with the details, but I don't know if we can share that round. But I think it'd be a good event to support some of what we've done as a committee here, and
If you email it to Elliot, then Elliot can make sure it gets to the right people.
Okay.
Is that all right, Will?
Yep.
Mary?
I was invited to be the opening speaker for the social prescribing conference the other day, and I just really wondered whether everybody knows what social prescribing is and how much of a benefit it can be, and whether it's perhaps worthwhile having, and I've forgotten what he's called now, to speak about social prescribing, because that is playing quite a bit within the sort of preventative field, and I think that might be quite useful. I'm sorry, I've forgotten his name, but is Tom? No, I can't think. But anyway, I've got his name in the other room, but still, all right.
Thank you all.
Do we just turn up on Tuesday morning, just meet
Oh, yes, 9:30, I think, outside the building.
outside?